Good evening. For those of you who don't know me, I'm Jane Carter, and as President of the Union, it's my pleasure to welcome you to the 45th Union World Conference on Lung Health here in Barcelona. The theme of the conference this year is community-driven solutions. That topic led me to begin to think about the meaning of community. The first definition of community I stumbled across was a body of people viewed collectively. In 1920, a group of 31 national TB associations came together to form the union to fight tuberculosis. This was a community and remains a community today. At the President's Centennial Dinner last evening, we heard the story of Tatu Mosidi. Tatu is a young physician living and working in her homeland of South Africa. Last year, Tatu was diagnosed not merely with TB, but with XDR-TB. In that one moment, the moment Tatu was told her diagnosis, she moved from the community of TB fighters to that of TB patients. In that one moment, Tatu joined a community of 9 million patients with TB last year, a community of TB patients where 1.5 million will die, a community where 3 million patients will never receive care. The story she related last night certainly suggested what the TB community needs to do. Her story called for a world in which her work as a physician in the public sector did not place her at risk for disease. Her story called for a world in which a diagnosis of TB no longer could seem acceptable or the norm. Her story called for a world in which treatment was shortened, in which treatment did not assume side effects, and in which treatment was not limited to the lucky few. Yes, Tatu is part of that TB community, and her story must drive us all to find those solutions. But community is also defined as a group of people who share the same interests, pursuits, or occupation, especially when distinct from those of the society in which they live. That places us, you and me and Tatu, in the same group. We all share the same interest, the same goal, to eliminate TB, to reduce the suffering of TB, to reduce the deaths caused by TB, to reduce the burden of TB. I believe that the power of that goal is the fact that we are a community. We are a diverse community made up of patients, physicians, researchers, caregivers, educators, and so many more. We each bring our talents to finding the solution that will ease pain, reduce suffering, eliminate the disease. Together we are stronger. Together we will triumph. As a community, we say, yes, we can. Today is the start. Today will be the next step on the journey that our founders started in 1920. On this stage tonight, we honor Tatu and her story, and we promise not to stop working together in our TB community until no patient is left behind, no patient is left untreated, no patient is left uncured. Tonight is the new beginning. Let's begin to make that promise to eliminate TB come true. Please enjoy the conference. I challenge you to make new connections, to build our community, and to improve our strength to take on the task ahead. The power to achieve our mission lies in each of us and in the power generated by our coming together as a community for a common goal. Thank you, and I'm pleased to open the 45th Congress. Okay. To open our program this evening, I'd like to call to the podium two of our activists, Portia Sarate and Stephanie Aksanyan.
Thank you very much for being granted this opportunity. My name is Portia Serote. I'm the National Women's Rep of Treatment Action Campaign. I would love to share with you a bit of my story of how is it like to live with TB, the challenges that we come across. Immediately after being diagnosed with HIV, I was also diagnosed with TB, but it was pulmonary TB. It was so hard for me to understand why are they giving me this treatment, because at that time I was not having the signs and symptoms of a TB. And immediately after being given the treatment, I started facing challenges. My skin started changing into being dark, my lips started changing into being pink, I had peripheral neuropathy, I couldn't walk properly, and it was a challenge because these drugs need something to eat. Each and every 5 minutes of taking the Rifa-4, you will need something to eat. And our countries have good policies in place, like the National Strategic Plan that says treatment, care, and support. But what is happening actually is that they only provide treatment and they do nothing about care. And that is a problem. Hence, in most countries, we are faced with a lot of defaulter rate. For me, it is useless for people to be diagnosed and at the end of the day do not take treatment, and at the end of the day just drop out, and we are failing to trace them. I will make a critical example about this. In 2012, where I'm coming from, 14,161 patients were diagnosed with MDR-TB. And out of that number, only 6,494 patients were initiated on treatment. The question that we are asking ourselves as activists is, where are the 7,667 patients who are living with MDR? We all know science today that TB is an airborne. Even if you didn't have TB, once you get contact with that person who is not getting treatment, you are at risk of getting MDR. What we are calling for today as activists, we met here globally, different countries. We are saying to all of you, together we can make a difference. We need, when policies are made, we need to be part of them, because we are at the ground level where the actual things are happening. So we can together make a policy that is informed by everything that is happening. We need to have better drugs. I don't want to, if I nearly failed to take my treatment, I was taking 6 Rifa-4 a day on daily basis because of that time I was big. If I was failing to take 6 drugs a day, what about a patient who is having MDR, who is supposed to be taking 14,600 tablets for 2 years, and that person also have to go through injectables every day in her daily life? That is so sad. Whilst we know that there are better drugs, we have delaminate, we have bedaquiline, we have linalazid. I don't want to talk about the side effects of the treatment that we are using recently, but because there are people who are going to talk about MDR and XDR-TB. What we are saying is that in order to have 0 new infections on TB, in order to have 0 death caused by TB, we need more funding for TB. We need more money to be put for research so that TB is taken into consideration. We need TB to be taken into much consideration like HIV. We said in one of the big meetings like this, we said we need to collaborate all into one. We said we can't separate TB and HIV and STIs. So today, as activists here, we are calling for that. So thank you.
Hi, I'm Stephanie. I'm here because my brother in Los Angeles, California has XDR-TB at the age of 35 years old. This has been a very difficult process for him, obviously, and for our entire family. One, because he has very limited resources on medication, and the medication that he is currently taking is taking a toll on him mentally, physically, and emotionally. For instance, he has neuropathy in his hands and his feet that has now gone up to his knees. So the problem is, the doctors keep saying, just tough it out, because we don't have any more other options. We are completely out of medication to give you, this is it. So, and the old drugs, I'm so sorry, this is so difficult to talk about. The drugs are old, and some of the new ones are not available under compassionate use. could do this. So we need more options, is all I'm saying. We need more options. And I have a perfect candidate. My brother couldn't be here, but there's someone else here who is a perfect example of who needs options. Someone named Ricardo. Can you please come up here, Ricardo? Ricardo has XDR TB, and he has had TB for 18 years. And he is currently still fighting his battle. And he is strong. He works every single day. He works every single day. And his wife? Okay, so I'm wondering, when is it going to stop? Why is it so tough to get treatment for people? We need new research for TB drugs that are safer, more effective, and patient-friendly. Last year, the world combined only spent $3 million on new drugs for TB. I'm so sorry. These numbers are astounding. I'm just so overwhelmed. The pharmaceutical industry needs to step up their game. They have abandoned TB, which is astonishing because TB was declared a global emergency, and yet they have abandoned Ricardo and my brother and everyone else. We need more research. So today I call on donors, governments, pharmaceutical industries to cough up the money, cough it up. Cough up the money for TB so my brother, Ricardo, and everyone around the world can get the treatment they deserve and the lifestyle they deserve to live without the side effects. So sign, you guys. Everybody sign at the end of here. I've already started a petition. We have a petition. So please, I beg of you, all of you, please go ahead and sign the petition so we can get more money and more funding because everybody needs it.
So what do we want everyone to do? Cough up the money for TB, right? Right? Cough up the money for TB. Cough up the money. Woo! You guys can do it. Yeah?
Thank you, Portia and Stephanie and Ricardo, for your passion and for being part of our community. I'd like to just take a moment for everyone to remember two people that we lost this year. At this point in the agenda, we usually stop and reflect on deaths within our community, and I'd like to just take a moment to for a moment of silence for Glenn Thomas and all of those who lost their lives on Malaysian Airlines MH17, and for the loss of our recent colleague, Professor Felix Salampani. Thank you. This year we have 4 speakers for the evening's agenda, all passionate about creating a world free of TB. In fact, 3 of our speakers come to us fresh from the first ever Global Tuberculosis Symposium held here yesterday and organized by the World Health Organization, focusing on a need for out-of-box action to beat TB, built on the fundamentals of quality TB prevention, care, and control. It is my great honor to introduce our first speaker, Dr. Harsh Vandhan, the Minister of Health and Family Welfare in India. He is passionately pushing for ambitious targets in the battle against TB, leading the effort in India and globally to act now. In India, in his first 6 months in office, he's introduced tough new policies in tobacco, increasing taxes on tobacco and increasing the size of health warnings on all cigarette packets. We're delighted that he's able to join us tonight.
No, it's okay. It's okay. It's okay. President of the Union, respected Dr. Jane Carter, my dear colleague, Health Minister of South Africa, Dr. Aaron, respected dignitaries sitting on the dais, and very passionate soldiers of the tuberculosis elimination army from various parts of the world. Friends, I have been to many international conferences in the past, but the type of enthusiasm and commitment that I have seen from the participants here, that is really commendable. And before I say something, I salute all of you for the tremendous spirit that you have pursued over the years, and for the commitment that you have to work for that day when we can really eliminate a disease like tuberculosis from the face of the earth. Yesterday morning, when I spoke at the WHO symposium and delivered the keynote address, I had shared many of my views there. I'm really grateful to the Union for once again giving me this privilege today to share my views with all of you. And I can see many of you were present yesterday also. On behalf of the Government of India, it's my real privilege and pleasure to be part of this landmark meeting being organized here in Barcelona for the 45th Union World Conference on Lung Health. Friends, India has taken a series of bold steps in the recent past, such as identifying high-impact interventions and addressing policy gaps for their implementation, prioritization of geographies, and increased financial allocations to these areas, employing flexibilities in terms of relaxation of norms in hilly, tribal, and difficult areas, rigorous monitoring and harmonized technical assistance by our development partners. Active national leadership and critical development partner support have been the hallmarks of the nationwide rollout against tuberculosis. India is committed to take a leadership role in ending preventable deaths from tuberculosis, both within India as well as globally. Friends, it has been observed that community engagement and patient-centered approaches are a key to tackling tuberculosis. A purely biomedical approach to fighting the disease is likely to fail, as the patient is a part of a family and society. In earlier years, patients and families were often blamed for suboptimal outcomes from treatment. Example is treatment interruption, development of drug resistance, and things like that. However, over time, we have shifted the responsibility to the health sector to own the patient, not only for early diagnosis of his disease, but also for successful completion of his or her treatment. The public health approach to tuberculosis control rests on early detection of the tuberculosis cases, followed by cure. Once a family understands that TB is curable, that it has nothing to do with poor sanitation and hygiene, and that it can affect anyone in the community, case detection becomes a shared responsibility. Successful treatment outcomes become everyone's concern, more so of the health department. The recent Global TB Report 2014 has reported that 3 million people with tuberculosis were missed, either because they were not diagnosed or because they were diagnosed but not reported. 510,000 women died of tuberculosis, and that accounts as being one of the topmost killers of women in the reproductive age. An estimated 550,000 children became ill with tuberculosis, and as India accounts for 24% of the global TB cases, the challenge for us remains colossal. A strong vision and leadership by governments can make a critical contribution to further accelerate the momentum already in place to end preventable deaths. As members of this August forum, we must return to our countries and review comprehensively our progress to date, identify the next steps, and do whatever is needed and in our power to take this initiative to the next level. Transparency and mutual accountability can be achieved through country-led, inclusive, transparent, and participatory oversight processes. On behalf of the global health leaders, I would like to take this opportunity to propose 6 key actions that will enable us to accelerate our efforts in making tuberculosis history. Number 1 is the power of belief. In the mid-1990s, as the health minister of the state of Delhi, I had the privilege to be one of the architects of the polio eradication campaign in India. World Health Organization in 1988, at the World Health Assembly, called upon the member nations to eradicate polio from the world. At that point of time, no one could believe that India, which accounted for more than 60% of the global polio burden, would ever be able to achieve polio-free status. The global community thought India as a major bottleneck in achieving this milestone, but the power of belief guided me to launch the polio eradication campaign in the year 1994 as Health Minister of Delhi State. I successfully applied the learnings from the robust electoral model of India, the largest democracy of the world, where much larger scale of mobilization is needed. The certification of India being polio-free signifies the power of belief. Therefore, this year is a very special year for me and for all fellow Indians. Let us not underestimate the power of believing that we can end considerable morbidity and preventable deaths from tuberculosis also. Now is the time for action towards this cause, although not optimal. However, we have the necessary interventions and tools in place. What is needed first is the belief that we can end and not merely reduce preventable deaths. We must provide the leadership to instill this vision in the minds and hearts of other leaders, millions of healthcare providers, and in the minds and hearts of the men, women, young people, and children we seek to serve. Our belief must catalyze widespread commitment that will accelerate action. Second, there is great power in partnerships. This is the second principle that I would like all of us to follow. Colleagues, we must forge new partnerships to catalyze transformative impact in bringing an end to morbidity and mortality due to tuberculosis. This cannot be achieved by working in silos. Governments, development partners, civil society, private and corporate sector, community leaders, the media, and the public at large all have critical roles to play if we have to engineer the social change needed to end preventable deaths. Friends, I would like to highlight the important role played by the development partners who have provided high-quality techno-managerial support. This enabled us to reach out to the most vulnerable and marginalized populations in the most difficult-to-reach areas across the length and breadth of our country. For this, I would like to place on record my appreciation for the unstinting support extended by the development partners such as the USAID, GFATM, the World Bank, the World Health Organization, the Union, DFID, BMGF, and fined for tuberculosis. And there are many others I have not named, but they all deserve appreciation, they all deserve commendation. Colleagues, we must now find ways to forge alliances with the private sector in particular, both as a resource and as a provider of products and services. Private sector partners also have much to teach us about innovation, sustainability, and models to achieve the last mile coverage. Recently in India, the corporate sector has been made accountable under the new companies law, which make it mandatory for them to invest 2% of their annual profits for the benefit of society as part of their corporate social responsibility. My endeavor would be to get maximum funding under the corporate social responsibility for investment in the health sector to prevent morbidity and mortality arising due to tuberculosis. This will also greatly facilitate extending their focus beyond commercial viability to include social benefits as well as greater public health impact. Friends, the third thing that I wish to emphasize is that there is untapped power in health financing and organization. Globally, we now have the evidence to show that greater economic growth ensues from increased spending on health. Without thoughtful organization of the health system and without financing mechanisms to channel resources for maximum health impact, we know that we end up with inefficient health systems that often exacerbate existing inequalities. Colleagues, we must provide the leadership to implement strategies for universal health coverage to ensure that people have access to quality, preventive, curative, and rehabilitative health services with minimal out-of-pocket expenditure. Friends, the fourth point that I wish to emphasize is about the power of evidence. The research conducted by Tuberculosis Research Center and the National TB Institute from India and various other organizations have provided ample evidence in the past for policy formulation. India has recently embarked on conduction of first nationwide world's biggest drug resistance survey, which would provide us realistic estimates of the problem against multi-drug resistance at hand. However, there has been very small improvement in the disease burden, though there has been significant decrease in mortality. Colleagues, we must ensure more rigorous collection, analysis, and dissemination of population and service utilization data, and the inclusion of sustainable development indicators such as poverty reduction, addressing malnutrition, housing, education, access to quality of health care in general. We must also lead efforts to ensure that we measure the impact of our investments for saving the lives of those affected by tuberculosis. This will usher in accountability and guide our collective investments. We should support innovations in information systems, including tapping into the incredible power of technology that enables us to reach out to providers in remote locations and even individuals on a real-time basis. Friends, the fifth point that I wish to emphasize today at this August forum is the tremendous power in communication. Our ability to communicate with individuals, whether they are mothers, fathers, girls, or boys, or providers of care to families and individuals, has immense potential to change behaviors. We must provide the leadership to stimulate and sustain individual and social behavior change for better health outcomes. We must work in partnership with communities who bring their own capital to the generation of good health. We should encourage every individual's participation for positive health. In my personal experience, I have found tremendous value in involving adolescents and youth to communicate and disseminate messages of positive health. Just now you saw the enthusiasm and the commitment of the young women who were here on the stage. Like the power of evidence, our efforts can leverage the explosion of technology and social media to achieve our goals more rapidly. Today, technology can help us reach out to more people than ever before, and in ways we could not have imagined earlier. The power of communication is the hallmark of the 21st century and will act as a force multiplier in our efforts to control and eliminate tuberculosis. Finally, I would like to highlight before you the power of gender equality. Despite efforts to bring the spotlight on and address inequalities between men and women, boys and girls, rich and poor, rural and urban, we all know that gender inequalities continue to undermine our efforts for improving the health of our populations. Gender inequalities are especially pernicious in their impact on the health of women and particularly children. Yet, we still continue to struggle to systematically and effectively redress gender inequality. This may be one of the most difficult challenges we face. Nonetheless, we must provide the leadership to systematically promote gender equality at scale. Innovative strategies to strengthen this partnership is the need of the hour. If we need to curb the spread of tuberculosis. Friends, I would like to conclude by saying that it is our collective responsibility to ensure that our investments and the benefits of development reach everyone who is susceptible to be affected by tuberculosis, for creating a better future for the generations to come. Otherwise, the future generation of people will not forgive us for our slackness today. The globe has now realized that without community engagement and forging partnerships, we are not anywhere near tuberculosis elimination. Let this conference pave the way for new thinking and innovative strategies so that we can finally boast of a tuberculosis-free world. Thank you. Jai Hind.
Thank you, Dr. Vardhan. This year's Sir John Crofton Memorial Lecture is given by the Right Honourable Nick Herbert, who is a Member of Parliament in the UK. Since becoming an MP, he has worked closely with the development charity Results on the global problem of tuberculosis. In 2006, he helped to form and was elected co-chair of the all-party parliamentary group on global TB, and then was returned as the co-chairman in 2013. I want to thank Nick, as I call him up to the podium today, for his incredible leadership in TB globally. On Monday this week, he convened with the support of the Union parliamentarians from 7 different countries to galvanize a global caucus that will do everything in their power to fight tuberculosis. I'm happy to welcome him to the stage to tell you about that initiative.
Good evening, ladies and gentlemen. The eyes of the world are focused on a condition that cannot be cured. Leaders in medical sciences are hunting for a solution to a disease that threatens the lives of rich and poor. The only protection is to stay away from the sick. Governments have come together to launch the fight back. Such words fill the daily newspapers. But they are not today's headlines about Ebola. They are the reports of nearly a century ago, when 31 countries came together from around the world to form the institution that we now know as the Union. And the threat was tuberculosis. Within a year, a vaccine was discovered. 30 years later, there was a breakthrough with the discovery of streptomycin. The drug would change history, not only because it was the first drug against the deadliest disease in human history, but because the scientists who discovered it thought outside of the box. First, they conducted a randomized control trial, proving the efficacy of the drug beyond doubt. Then they realized that to beat TB, it required not one drug, but several, acting in combination to tackle the disease. They paved the way for future treatments for cancer and for HIV. They created modern medicine as we know it. That team was led by a man called Sir John Crofton, and his vision has saved millions of lives. I'm honored to be standing here and delivering this lecture, which bears his name, and to join a distinguished audience of those who have dedicated so much to try to combat TB. Later this evening, we will hear singers perform, and we will be reminded that when La Traviata and La Bohème first played in the opera houses of Europe, the portrayal of young women coughing their last breath was unremarkable. The disease then accounted for 1/4 of all deaths. Today, most citizens in the West believe that TB is beaten, a disease of the past, with a vaccine and treatment readily available. I thought that when, as a newly elected member of Parliament in the UK, I was first told about TB. How wrong I was, and how wrong they are. TB has made a terrible comeback. Always a disease of poverty, now linked to HIV/AIDS, it remains a killer of millions. And as we know, there has never been an effective vaccine. Now, this oldest of diseases is producing the newest of threats. Drug-resistant strains now account for 1/3 of all deaths from the disease. Those with access to advanced health care who contract drug-resistant TB face a long and extremely unpleasant course of treatment, but stand a chance of living. For those in less developed countries, it is usually a death sentence. Last year, a Time magazine cover sensationally declared, "Contagion, why drug-resistant TB threatens us all." Now, media attention is on a new threat. 2 months ago, the World Health Organization declared the Ebola epidemic to be an international public health emergency. But TB was declared an emergency 2 decades ago, and since then, it has claimed more than 25 million lives. As new threats like Ebola rightly command concern and attention, we need to remind political leaders that TB still kills as many people every day as Ebola has in total. The world cannot afford to make choices between tackling these terrible diseases. It must fight on every front to beat these epidemics. Yes, the rate of new cases of TB has been falling worldwide for about a decade, enough to hit the UN's Millennium Development Goal target. Yes, deaths will have nearly halved since 1990. But as the Stop TB Partnership pointed out this week, in response to the latest WHO report, that's the global picture. The figures also show that in Eastern Europe and Central Asia, Africa and the Eastern Mediterranean regions, new TB cases are not decreasing and targets will not be met. There are still 9 million new TB cases every year and 1.5 million deaths every year from this curable disease. The report confirms that the decline in new cases continues, but at a rate of just 1.5%. That's nothing like the 10% annual reductions which enabled the West to get on top of the disease. If we continue at this rate, we will be waiting another 2 centuries before we eliminate TB as a pandemic. The latest WHO report says that 3.3 million people a year who develop TB are being missed by health programs. Most worryingly, less than 1/4 of drug-resistant cases are being detected, and less than half of those that are detected are successfully treated. It's unsurprising that drug resistance should have occurred. TB is treated with drugs developed over 60 years ago. Long courses of antibiotics administered in patchy or non-existent healthcare systems where counterfeit pills are rife make non-completion of drug regimes a constant risk. Indeed, the entire apparatus to control TB in high-burden countries is pitifully antiquated, with treatment regimens that are long, complicated and with huge side effects, and with a vaccine that is 90 years old. If this had been a disease that had resurged in the West, we would by now have a new vaccine, rapid testing, and better drugs. But there was no commercial market for these lifesavers, and so the pharmaceutical companies bluntly had little interest in developing them. Only the intervention of the West, through massive aid programs and partnership funding for research, can change this story. Political commitment and new resources are needed. The Global Fund provides over 80% of all international funding to fight TB, so its replenishment has been crucial. I am proud of the £1 billion commitment which the UK has made to the fund, and many other wealthy countries have also played their full part. But others need to step up to the plate. And we need to recognize that there's still a funding gap in the overall fight against TB. According to the WHO, $2 billion of the $8 billion needed every year to ensure a full response are missing. So we have a post-2015 WHO strategy which aims to end the TB pandemic by 2035, but right now a quarter of the resources needed have not been found, never mind in the years to follow. It's hard for Western leaders to commit money at a time of austerity. But quite apart from the moral obligation, TB is a disease that does not recognize national borders. We have a common interest in fighting it. The rising treatment costs of inaction, particularly in respect of drug-resistant TB, argue for intervention now. And the tragedy of TB is that it's claiming millions of lives still, yet no one is talking about it. I knew very little about the disease before I saw its impact for myself. 9 years ago, as a newly elected MP, I joined a small group of UK parliamentarians who visited Kenya with a charity called Results UK. That visit opened my eyes to a global health catastrophe. I remember visiting a hospital in Nyanza province where TB patients shared beds and some slept on the floor. On returning from that trip to Kenya, 3 of us decided to establish the all-party parliamentary group on global TB. In the 9 years since we established it, it has made a real difference to the political debate in the UK. Colleagues in Canada and the United States have similar groups. This World TB Day, we started to reach out to our colleagues in other countries, and we were delighted by the response. Over 170 members of Parliament from across the G7 countries signed our World TB Day statement calling for an end to the disease. And that gave us the idea to hold a global summit of parliamentarians. Thanks to the unstinting support of Jose Castro, the Union on Monday elected representatives from countries spanning 5 continents, from the United States, Canada, Brazil, the UK, France, India, South Africa, Kenya, and Tanzania, met here in Barcelona to discuss the TB epidemic or sent their support. We heard from Dr. Mario Raviglione of the World Health Organization's plan to beat TB, but of the challenge the world faces to meet the new targets. We heard from Dr. Luchika Dishu of the Stop TB Partnership about the need to step up the response. And so we agreed to form a new global parliamentary caucus to urge for new action and resources to fight this disease. And today we are launching this declaration. We, the undersigned, as political representatives of various peoples of the world, recognizing that every man, woman, and child should be able to live their lives free from the tyranny of disease, hereby declare that tuberculosis has killed a greater number of people than any other infectious disease in human history, and continues to be responsible for 1.5 million deaths a year, often affecting the most vulnerable, and that it should be a global political priority. That the current rate of progress in combating TB is too slow, such that the disease will remain a threat to the social and economic well-being of millions of citizens around the world for centuries to come, and that accelerating progress against the disease should be recognized by all governments to be in the interests of all. That drug-resistant TB demonstrates a collective failure to address the disease properly, imposing an often unbearable burden of treatment on patients and threatening to set back progress against the disease at the grave cost of millions of lives, and that it should be the focus for urgent action. That the current drugs for TB treatment are inadequate, that vaccines and diagnostics are insufficient, and that the commercial market for pharmaceutical development has failed TB patients. That TB imposes on patients a triple burden, combining the devastating health impact of the disease itself, the harsh burden of treatment, and the isolation of social exclusion driven by stigma and fear, and that these problems should be addressed holistically by national health programs. That co-infections with TB, such as HIV and diabetes, compound the challenges faced by patients during treatment, hindering efforts to reduce rates of disease and increasing the mortality and morbidity associated with TB, and that healthcare systems should integrate programs for key co-infections. We therefore commit to use all of the means at our disposal to urge sustained action from our governments, to secure the necessary international and domestic resources to combat TB, and to press for the prioritization of the disease on political agendas, specifically to demand that every patient, regardless of who they are, where they live, or their ability to pay, shall have access to quick, accurate diagnosis and high-quality treatment, and that TB diagnosis and treatment never results in the impoverishment of patients or their families. To call for a model of research and development that is driven by public health need and will still support and enhance existing pipelines of desperately needed new drugs, diagnostics and vaccines to ensure that new treatments are accessible and affordable for the patients who need them. To insist that patients and vulnerable groups are placed at the heart of the response to the disease. The engagement of communities and civil society groups in every aspect of TB prevention, detection and treatment, puncturing stigma and giving patients a stronger voice in the response to the epidemic. And to this effect, we hereby agree to establish a new global parliamentary caucus to press for a more effective response to the TB epidemic, working with official organizations including the WHO, UNITAID, the Global Fund, the Stop TB Partnership, the Union and UNAIDS, and with non-governmental organizations across the world, reaching across political and geographical divides and seeking to build commitment in our own countries and beyond to secure an end to the TB epidemic within a generation. So that is our declaration. We plan to meet again at the Union Conference in Cape Town next year. By then, we want members of Parliament from 100 different countries to have signed this declaration and joined our global parliamentary caucus. And we need your help to secure their support. The nations of the world are represented in this room. You are all committed to the fight against TB. Most of you have elected representatives. And ladies and gentlemen, we work for you. How many of you in this room have lobbied your elected representative? If you haven't, now is the time to start. Tell them about TB. Explain to them why it matters. Ask them to raise these issues. Ask them to join our caucus. If no one had asked me 9 years ago, I wouldn't be here now. Ladies and gentlemen, I addressed your conference 7 years ago, and since then 10 million lives have been lost. We've made some progress. We have an effective new diagnostic tool. For the first time, we have a number of promising drug candidates. For the first time, we've taken a TB vaccine through stage 2 clinical trials. The Global Fund has swung into action. There's been real progress in some countries. South Africa has launched the biggest HIV treatment program in the world and a similarly enormous campaign to reduce rates of TB. I particularly want to thank the Minister of Health for South Africa, the Honourable Dr. Aaron Motsoaledi, for his superb leadership. India is making determined progress in tackling its own huge epidemic. I was hugely impressed to hear the candor of India's new health minister, Dr. Harsh Vardhan, who has urged a step change in the battle against TB in his own country. We know that existing efforts across the world are not enough, and it's time to do something about it. Perhaps I will be invited to address you again in 7 years' time. And you, we in this room, have to decide if we want to change things by then. Will another 10 million lives have been lost? I say we can't go on like this. If you want change, then stand up now. Stand up and say that it's time to stop TB. Stand up and say, we refuse to be here in 10 years' time, in 20 years' time, and still see such small annual reductions in this disease, which afflicts the poorest and the weakest in society most of all. Stand up and say, it's in our collective power to stop this, if we have the ambition to do better. Stand up and call on the people who represent you to act. Stand up and say 200 years is too long. We can beat TB in a generation, and we must. Thank you.
Thank you very much, Nick, for that inspiration. Our third speaker is a longtime TB nurse in the Cape Town area, and as such, Ria Grant became aware of how crucial a TB patient's social environment is to both causing and curing the disease. Following early work as a TB nurse, she became a caseworker for TB Care, now the TB HIV Care Association, working closely with patients to address their clinical, material, and psychosocial needs. She later became director of the TB HIV Care Association and has also served as the African Regional Communications Focal Point and Lead Communications Focal Point for the Developing Countries NGO Delegation to the Global Fund. It gives me great pleasure to welcome Ria to the stage to speak about the role of communities in the management and care of patients living with HIV, TB, and other lung diseases.
Good evening, everybody. I don't know how I'm going to follow that powerful speech, but I'll try. There are 4 reasons why communities have a role in the management of care of persons living with tuberculosis, HIV, and other lung health issues. They can advocate for improved service delivery. They can provide care and support in the community. They can reduce the workload within facilities. And with the right messages, they can be motivated to change behavior. I had been cocooned in a hospital environment for 4 years during my training as a professional nurse. My introduction to communities and tuberculosis was in 1966. I was a young, newly qualified, freshly appointed TB nurse in a TB clinic in Cape Town, South Africa, administering streptomycin injections daily and packing monthly supplies of PAS, Iron H, and vitamin B Co for the patients with some of my tasks. 24 PAS, 6 Iron H, 2 vitamin B complex tablets daily, multiply that by 30 days, and you can imagine it took some counting. It was here that I came face to face with the realities of life in the community. 1966 in Cape Town was a very sad time. The forced removal of people based on their race had begun. The PAS laws were being enforced with a vengeance by spectres trawling the suburbs in white vans. People were being uprooted, loaded onto lorries with their possessions, and moved into a foreign environment. They had to leave homes where they were born, where their parents were born, and their parents before them, to this very harsh, high-density living areas out in the Cape Flats. It was a nightmare for TB case holding. Many of the patients were so-called illegal migrant workers from the rural areas, and the white van often arrived at the health facility to check for passes amongst the patients attending for treatment. We became adept at hiding people in the darkroom when the sentry reported that the white van was approaching. Imagine living under those stressful conditions. But that was all in the past, thank goodness. Communities can advocate for improved service delivery and contribute to policy development. Barriers to care are real challenges for people all over the world. Finding money to travel to a facility, if it's not within easy walking distance, poor record keeping, which results in additional and unnecessary visits to the facility, staff attitudes towards sex workers, gays, lesbians, tattooed released prisoners and young people, drug stockouts, reduced income because of the hours spent at crowded facilities, waiting, always waiting. And of course, 2 diseases in the same body being treated in 2 different buildings by 2 different medical teams, and sometimes even on different days. Picture this. You live right at the top of this hill, and this hill can be anywhere in the world. You're not feeling very well, and you really want to get better. So very, very early in the morning, you take the long road down that hill with the money you've borrowed to travel to the facility which lies over the next 2 hills. You want your results, and you want some medication. You sit waiting there for almost the whole day with nothing to eat, and then the nurse, through no fault of her own, tells you that they're sorry, but they cannot find your records, and that you should return next week. Or the truck did not arrive with the supplies, and the medication hasn't arrived. Or worse still, we cannot see any more patients today. It happens. It happens all over the world. Communities can provide care and support. My second point. NGOs were involved in TB patients in the community for as long as I can remember, but they were either running hospitals and sanatoria and providing handouts. Volunteers assisted with small fundraising events to buy blankets and food parcels for indigent TB patients. It was in 1992, I had left the health services and was managing, managing TB Care Association. In collaboration with other stakeholders, we implemented a community-based TB DOT program. That was when I realized what impact community involvement could have on treatment adherence in a community. We trained people from the community to administer DOT from their homes to TB patients on the street where they lived, access to care, access to treatment, no waiting. It took some effort to convince the nurses then, but now they could not imagine doing without their community care workers. It was extremely rewarding to see the growth and personal development of the recruits from the day they started their training, bearing in mind that most of the trainees were women, upward of 30 years, and had been extremely marginalized group in society. The training and the fact that they were to earn a small stipend opened a whole new window in their world. Not only that, for some it was the start of a career path to nursing, social work, and professional childminding. The best example of a patient-centered enabling environment I ever witnessed was observing the interaction between a patient and a treatment supporter in a shack in Shantytown. I was very proud, not only was there a clean glass of water freshly poured, but next to it a slice of bread on the plate. What graciousness when someone with so little to spare is still able to share. I was very proud of what we were achieving in this program, and I wanted to tell the world. I submitted an abstract to the union, which was accepted, and I arrived in Paris with my poster in 1997, ready to tell the world. I was warned that it was a very scientific conference with a small group of nurses and lots of doctors. But I still thought that I would be inundated with questions and people wanting to know how we did this and why we did it and how well it's working. Alas, only one person came to talk to me during that whole hour that I stood next to my poster. And that was Dr. Ian Smith, who subsequently invited me to the TB-Net conference in Kathmandu. But that's another story. Now, here I am, 17 years later, and I have my opportunity. All good things are worth waiting for. The third point is communities can reduce the workloads within facilities. Through counselling and treatment literacy education, more TB and HIV patients are placed out in the community with the support from the community care workers. Fewer feet through the door at the facility on a daily basis must mean more time to spend providing quality care and managing the facility efficiently. When my organisation was really struggling to make ends meet, I phoned the head of health and said that we would have to send 5,000 patients back to the facilities by the end of the following month. He invited me to his office, and that was the start of a long funding relationship with our provincial government. Just as an aside, can anyone tell me why treatment literacy for people living with HIV was introduced almost immediately, and yet no one thought of treatment literacy as part of a TB patient's treatment plan? We told them what they should and what they shouldn't do, and we must watch them swallow their pills, and even threatened them with death if they didn't comply. The fourth point. Communities can be motivated to change behaviour with the right messages. Why? Because they understand the environment and they understand each other. They can communicate in a language with their neighbour and their children, and they can be understood. It was Nelson Mandela who said, "If you talk to a man in a language he understands, that goes to his head. If you talk to him in his language, that goes to his heart." Communities are so aware of their own health needs. They are the ones who are affected by TB in their families. It's their daughters and sons and partners who are HIV infected. They are the grannies who have to care for orphan grandchildren at an age when they lack energy and the means to cope with the responsibilities. Ask me, a day with my 5 grandchildren, and I have to take to my bed as soon as they leave. They are the parents of the youth who get involved in drugs. They are the victims of abusive relationships. They understand the cultures of their people. We need to step up awareness about TB in children, diabetes, harmful effects of smoking and alcohol. The clinicians, researchers, and the health workers are not the ones to do that. Involve communities in the messaging and let them do the job. The role of communities in the management and care of persons living with tuberculosis, HIV, and lung health issues. Is it a question? No, it is a statement. I'm 2 years short of 50 years in tuberculosis work, 10 years in the health services and 38 years in an NGO. Seen a lot and done a lot. And it is with confidence that I can tell you that communities have a vital role to play, but their involvement has to be well planned, well managed, sustainable, and they must never be taken for granted. It needs commitment from our governments. Mr. Minister, I know I can depend on you to make community system strengthening part and parcel of the strategic plan for health for any country. In conclusion, I was trained to be a nurse, and I'm still a nurse even though I have not given an injection or dressed a wound for many, many years. In this audience, there are many nurses making significant contributions to managing tuberculosis and HIV. Please look out for them. You will recognize them by this pin they're wearing. So fellow workers, colleagues, I have one last message for you from another community member from South Africa. Do your little bit of good wherever you are. It's those little bits of good put together that overwhelm the world.
Thank you, Ria. I'd now like to welcome Dr. Aaron Motsoaledi, the Minister of Health for South Africa and the Chair of the Stop TB Partnership Board, to the podium. Dr. Motsoaledi was in high school at the time of the Soweto uprisings of 1976, and he became active in the liberation struggle as a college and a medical student. He later became deputy chair of the ANC Transvaal, now Limpopo region, when it was launched in 1990, and served on the Limpopo Provincial Executive Committee of the ANC for 19 years. He was then elected to the ANC National Executive Committee, where he continues to serve today. Dr. Motsoaledi is one of the leading global voices in the fight against tuberculosis. He is a tireless advocate and is widely respected by everyone following the global movement to stop TB. I'm delighted to invite him to the podium to hear about an old disease, new ambitions, 0 TB deaths in our lifetime.
Program Director and President of the Union, Dr. Jane Carter, my colleague, Your Excellency, the Minister of Health and Family Welfare for India, Dr. Harshvardhan, Honorable Nick Herbert, Member of the UK Parliament and the co-chair of All-Party Parliamentary Group on Global TB in the UK, fellow parliamentarians, Ms. Ria Grant, member of the Developing Country NGO delegation to the Global Fund, ladies and gentlemen, dear friends, It's a great honor and privilege for me to participate in this 45th Union World Conference on Lung Health in this beautiful Spanish city of Barcelona. The theme of the conference, community-driven solution for the next generation, could not have been more apt because the disease that made us together here today can only be defeated with the central involvement and participation of all stakeholders working together, driven by a common vision, mission, and a set of targets. I am therefore very pleased that I'm sharing this platform with my fellow colleague, the Minister of Health in India, who has done a lot in his lifetime in this regard, but also with Honorable Nick Herbert, a fellow parliamentarian who has started to mobilize elected leaders to stand up and be counted. And I'm happy today that all of you here stood up. You are being counted one by one. In 1848, Rudolf Virchow said, and I quote, "Medical statistics will be our standard of measurement. We will weigh life for life and see where the dead lie thicker, among the workers or among the privileged," close quote. What Virchow said 166 years ago is true today, as it was then in 1848. Virchow pointed to the importance of the social determinants of health and the need for scientific rigor and measurement. As we focus on TB at this conference, we cannot be silent on social determinants of health, including the ever-widening disparities in many parts of the world. We know who are vulnerable, and we know what needs to be done. It is our generation that bears the responsibility to what is required in order to ensure that we are able to eliminate this pandemic in our lifetime. TB has been a deadly companion of human society through many millennia and appears to be able to resist everything that we have tried in the past. In his book, Infections and Inequalities, Professor Paul Farmer, the Presley professor at Harvard Medical School, made the following astute observation about what the World Health Organization said about TB, and I open quotes. In 1995, more people died of TB than any other year in history. At least 30 million people will die from tuberculosis in the next 10 years if current trends continue. Millions more will watch helplessly as friends and family members waste away, racked with coughing and sweating with fever. They may wish that medical science could cure this terrible disease. The truth is, medical science can. Since 1952, the world has had effective and powerful drugs that could make every single TB patient well again, close quote. Ladies and gentlemen, exactly 14 years ago, Professor Farmer himself again lamented the state of TB in the world, and I open quotes again. "The doctor in me insists that no one should die of tuberculosis today. It's completely curable. Yet, it is at the same time the world leading infectious cause of death among young adults. An estimated 3 million people are dying each year from tuberculosis. This figure comes as a surprise to many who read more frequently in their newspapers about Ebola or flesh-eating bacteria than about tuberculosis. Exerting its toll among the world's poor, tuberculosis has ceased to occasion much interest, either in scientific circles or in popular press. Tuberculosis has been virtually ignored for 20 years and more, close quote. A decade ago, our world icon, Nelson Mandela, himself a sufferer of TB, said the following during the International AIDS Conference held in Bangkok, Thailand. That was in 2004, and I quote, "The world has made defeating AIDS a top priority." This is a blessing, but TB remains ignored. Today, we are calling on the world to recognize that we can't fight AIDS unless we do much more to fight TB as well, close quote. Bar some progress, as reported in the recently released World Health Report by the World Health Organization, the world is today still confronted with the challenges of combating TB, despite these icons, as I've quoted, having noted that many decades ago. The Global TB Report 2014 estimates that 9 million people were infected with TB, and 1.5 million succumbed to its devastation in 2013. This situation is worsened by our inability to find 3 million of those infected in order to provide them with life-saving drugs. It is interesting that Professor Farmer made reference to Ebola, which coincidentally, 14 years later, has reared its head, with the outbreak currently sweeping through 3 countries in West Africa. This disease, with a case fatality rate of 50%, has grasped the attention of the world, maybe even more than HIV and AIDS, which is the twin epidemic to TB. As of the 25th of October 2014, there's been 10,141 cases notified and 4,922 deaths reported. The global response to Ebola has revealed 2 contradictory yet understandable sets of situations. It has revealed that the world can respond fairly rapidly to a health crisis, but also that our health systems, particularly in developing countries, are weak, especially with regard to community engagement, social mobilization, laboratory services, case management, surveillance, and contact tracing. I don't need to tell you that these will be the very same health requirements needed for the successful management of TB. Of course, the exception is the historic lack of global agency and resolve to fight TB, a disease that, as I've already said, infected and killed 9 million and 1.5 million people died from that, respectively, in 2013 alone. It seems as if we have grown accustomed to the presence of TB and also have come to accept the inevitability of the human suffering it causes. With familiarity comes the threat of fatalism and complacency. We have, until recently, had no new medicine to treat TB. In addition, our vaccine is 90 years old. As a global community, we spend less than a third of the money needed for the research to get us effective tools to beat this disease. As noted in the Global TB report, there is a 2 billion rand gap in funding for TB. Despite the progress reported by the Global TB report, this progress is far too slow, as it comes nowhere to what is needed to eliminate TB by 2035. The number of cases is reducing by only 1.5% per year. If we continue at this rate, it will take us 200 years to end the epidemic. I think we can all agree that none of us will be around by the year 2214. These statistics should send alarm bells ringing throughout the whole world. It should be a major wake-up call, just like Ebola is. How can it be that billions of dollars are spent on detecting and treating TB every year, and yet we don't see major reduction in new cases? What are we doing wrong? It appears to me that we are doing more of the same, even when we know that the strategies we are using are not giving us the acceleration we need. We need to ask ourselves some very difficult questions over the next coming few days of this conference. What do we need to do differently? We can learn from successes in fighting other diseases, such as providing bed nets against malaria, providing ARV treatment to people living with HIV/AIDS, which of course improve their quality of life, all of which seemed impossible before. We need to break down prejudices and structural obstacles to progress. We need to upscale interventions we know will work, such as TB screening of the vulnerable populations and preventative treatment. This includes mine workers, prisoners, children and people suffering from diabetes, people living next to the mines, that is people in the peri-mining communities. Closer collaboration and, in fact, integration of TB and HIV responses is critical to our success. The deadline for the Millennium Development Goals is December 2015, as we all know. Although the MDG process aimed to add impetus to the response needed to tackle underdevelopment, including public health challenges such as TB and HIV, there remains a lot of unfinished business that we should incorporate in our future plans. By now, we are aware that the direction to post-2015 World Development Agenda is already being set, and the agenda will constitute 3 areas in health. 1, that MDG 4, 5, and 6 must continue, and MDG 4 incorporates TB, HIV, AIDS, and malaria. 2, that we need to start facing the explosion of non-communicable diseases. And 3, that we need to start implementing universal health coverage. We should set ambitions, or rather we should set ambitious new goals to address the daunting challenges that will face our world over the coming 15 years, especially as many countries and regions seems to be off course in meeting MDG targets for TB. We need bold ideas and targets, and we can learn a lot from the manner in which we approach the HIV and AIDS pandemic. The World Health Organization and TB strategy, which was adopted in May this year, by health ministers from 194 countries during the World Health Assembly is a step in the right direction and an excellent platform to eliminate TB as a global pandemic by 2035. I'm sure you are all aware that having a good plan does not necessarily mean success. A good plan is only good when it gets implemented. Nonetheless, the strategy sets goals and outlines what needs to be done to reach the goals. The strategy is premised on 3 important pillars, namely integrated patient-centered TB care and prevention, bold policies and support systems, and intensified research and innovation. The strategy further is underpinned by 4 important principles. Principle number 1, government stewardship and accountability with monitoring and evaluation. Principle number 2, building a strong coalition with civil society and communities. Principle number 3, protecting and promoting human rights, ethics, and equity. And principle number 4, adaptation of the strategy and targets at country level. However, the strategy, as the 4th principle dictates, needs to be translated from these broad lines into action on the ground. We have no time to lose. We need to accelerate bending the curve of new infections downwards from a reduction of less than 2% per year to at least 10% per year by 2025 if we are to have any chance of succeeding. The Stop TB Partnership, which I have the privilege of serving as a chair, is, with technical expertise from WHO and other development partners, developing the next robust plan, Stop TB 2016 to 2020, which aims to provide concrete and costed proposals on how we can achieve our goal. The plan, which will be ready in a year's time, will suggest interventions that countries with similar challenges can use to break new ground in developing new additional actions to reduce new infections and save more lives. The plan will group countries into 9 different clusters. Countries with similar characteristics will come together, and a package will be outlined for interventions for each set of these countries. Ladies and gentlemen, at the recent International AIDS Conference in Melbourne, new HIV targets were announced. This is the 90 sets of targets. It is catchy and easy to remember and communicate. It says 90% of the people be tested for HIV, 90 of those tested positive initiate on treatment, and 90 of those on treatment are virally suppressed. This is the goals that were set in Melbourne. If we have accepted the 90 targets for HIV/AIDS, can't we adopt similar 90s for TB? Can't we aim to screen at least 90% of vulnerable groups for TB? Can't we aim to test at least 90% of those suspected of having TB? Can't we aim to initiate on treatment at least 90% of those that test positive within 2 days? And can't we aim to attain at least 90% treatment success rate for those on treatment? So, ladies and gentlemen, TB can also have its 4 90s if we agree so today. As the Minister of Health for South Africa, I've got the responsibility towards the country and fighting TB is a central part of that responsibility. But as the chair of the Stop TB Partnership Board and the partnership's 1,200 member organizations, I've even got a greater responsibility globally. And so I believe each one of us here has decided to attend this conference because we also feel that global responsibility. To the global fight against TB, we should all bring our collective strength, determination, and unbreakable optimism that is needed to defeat the disease. I believe we can see a world without deaths from TB in our lifetime. It is a vision I believe we all share, and I feel very strong about that vision. I wish you every success with this conference and wish you strength and new hope in the global fight against tuberculosis. Victory is inside. Thank you very much.
Thank you very much, Dr. Motsoaledi. We have now just a bit of a transition, and it's actually my pleasure to present to you Claire Perraud. Many of you will know Claire as the managing editor of the Union's 2 international scientific journals, and she's dedicated more than 20 years to the Union. But she's not here tonight to do any editing. What you don't know about Claire, or you might not know about Claire, is that she's also a talented soprano, regularly performing in and around France. She's most recently recorded an album of work inspired by the sheer number of musicians, composers, and artists affected by TB. Claire will be joined on the stage tonight by Barcelona soprano Maria Miro, who is also a physician and who also performs regularly in other TB-related events, and her pianist, David Harper, who recorded the CD project with Claire.
Tout autour de toi. Thank you, Claire, Maria, and David, for taking us to a very different place. It's always the highlight of the conference to be able to celebrate and recognize individuals who have made outstanding contributions to TB control and lung health. We will be presenting several awards today, sponsored by the union, our members, and partners. Our first award is the Princess Chichibu Memorial TB Global Award, and I would like to first welcome Dr. Toru Mori from the Japanese Anti-Tuberculosis Association to present the award.
Ladies and gentlemen, it's my great honor and pleasure to be here today at this ceremony to deliver the Princess Chichibu Memorial TB Global Award on behalf of Her Imperial Highness Princess Akishino, patroness of Japan Anti-Tuberculosis Association. This award has been given every year since 1998 by Japan Anti-TB Association in collaboration with the Union at the World Conference on Lung Health in recognition of the distinguished achievements to global anti-tuberculosis activities. Tuberculosis used to be so prevalent in Japan during 1930s and 40s. Late Princess Chichibu lost her husband due to TB at that time. She devoted herself throughout her life to the tuberculosis prevention, overcoming her personal grief as patroness of Japan Anti-Tuberculosis Association. This award was founded based upon her will to make the world free of TB. The winner of the award for 2014 is Dr. Muha Jeremiah Chakwa of Kenya. For his outstanding achievement in expanding tuberculosis control from Kenya to the world. Dr. Chakya is a clinical expert of TB and chest diseases based at the Center for Respiratory Diseases Research in Kenya Medical Research Institute. Also, Dr. Chakaya works as the technical director at Kenya Association for the Prevention of Tuberculosis and Lung Diseases. Internationally, Dr. Chakaya has served 3 terms as the chair of dose expansion working group of the Stop TB Partnership, as well as chair of Stag TB WHO. Now, ladies and gentlemen, I would like to invite Dr. Muhaya Jeremiah Chakaya to the podium to receive the year's award. Dr. Chakaya.
I'm deeply humbled by this award, and I'd like to thank God, my family, many of you as my friends and partners for this recognition. Certainly, the work continues, and yes, I think we need to find and cough out the TB money. Thank you.
Our next 3 awards are the Union Awards. Detailed information about each awardee is on the Union website. The first award is the Union Young Investigator Prize, the Unity Unit in the Department of Medicine at the University of Cape Town, South Africa. His research is focused on the design and field evaluation of diagnostics for tuberculosis and drug resistance. Grant recently led a landmark 4-country randomized control trial of the GeneXpert test for TB, which was the first to measure the clinical impact of the test and demonstrated it to be feasible at the point of care when performed by a minimally trained healthcare worker. Dr. Tehran is also a recipient of the Medical Research Council Silver Award and was selected as one of the top 100 South Africans by the Mail and Guardian newspaper. I'd like to invite Dr. Tehran to the stage to receive his award.
Thank you, first and foremost, to the union. I'm deeply honored. I would also just like to quickly thank my family for their unceasing support, as well as my colleagues in Cape Town, especially my mentor, Professor Kirtan Data. And finally, I'd like to thank the patients for whom I'm indebted to. And I would also like to finally endorse my colleagues at TAG's message to cough up the TB research money. Thank you. Thank you.
The Union Scientific Prize acknowledges researchers at any stage of their career for work on tuberculosis or lung health published in the last 5 years. It is an honor to award this prize to Dr. Richard Chasen, Professor of Medicine, Epidemiology, and International Health at the Johns Hopkins University School of Medicine and Bloomberg School of Public Health in Baltimore in the United States. He has worked in the TB and HIV research field for over 30 years and has been active in both clinical care and training of new clinicians and researchers. His research interests focus on tuberculosis and HIV infection, including global epidemiology, clinical trials, diagnostics, and public health interventions. From 2002 to 2014, he was the principal investigator of the Consortium to Respond Effectively to the AIDS and TB Epidemic, or CREATE, an international research consortium assessing the impact of novel strategies for controlling HIV-related TB at the population level. Dr. Chasen.
Thanks very much to the union for this great award, and thanks to all of my colleagues with whom I've collaborated for many years. Thanks to the funding agencies that did cough up the funding to support the research. And finally, thanks to all of the tens of thousands of participants in our trials which showed that TB can be prevented. Thank you.
Our next award is the Carl Stieblo Public Health Prize that acknowledges a health worker or community organization for contributions to tuberculosis control or lung health over a period of 10 years or more. This prize honors the memory of Dr. Carl Stieblo, who developed the strategy for TB control known as DOTS, which has been used to treat 5 million people since 1995. Dr. Martin Van Cleef is the TB Care Project Director at the KNCV Tuberculosis Foundation. He started his international career in Tanzania from 1991 to 1990. During this period, under guidance of Dr. Carl Stieblo and in collaboration with colleagues, Dr. Van Cleef played a key role in the implementation of a countrywide TB program using short-course chemotherapy. This programmatic field model became the model for the global TB control in the early 1990s, known as the DOT strategy. He continues to contribute to the international policy agenda in different forms. I would like to invite Dr. Van Cleef to accept his award.
Thank you very much. I feel very honored for this award. And particularly, I'm very privileged to have known Dr. Stieblo so long, and I worked so long with him. I got a lot of lectures, which I'm not going to mention now, but there is one lesson maybe to take away here to when I capture that as saying, don't lose the big picture, but don't lose sight of the small detail. I like to thank the union, everybody from the union, my friends, colleagues of the union for this, for the presentation of this award. My
KNCV, my organization where I work every day. It's a lot of pleasure to work there, and particularly my family is also sitting here. And last but not least, most of the people here in this room, friends and colleagues, and most of the people who are not in this room who couldn't make it, for this inspiration I got from the last of the many years I worked. Thank you very much.
Our final award is the Young Innovator in TB Research Award. And I would like to welcome the Executive Operating Officer and TB Global Project Leader of Otsuka, Mr. Masuhiro Yogashitake, and the Executive Director of the Union, Dr. Jose Luis Castro, to the stage to present the award.
So in collaboration with the union, we start this award this year. So fighting TB, requires new approach and innovation and outside box thinking. We hope this award will serve as a catalyst for next generation of leaders in research and development who take this enormous challenge. So I congratulate Dr. Julian B. Alaba for his impressive work conducting the operation research on pediatric TB in indigenous community in Venezuela. We look forward to more exciting research from you, and we make an important difference in fighting back against TB. Congratulations.
Thank you so much to Otsuka and the union for selecting me to be the first winner of this award. I would like to say thank you to all the people from Venezuela, the Netherlands, and US that helped me in my studies, to my family for their support, and to Drs. Santa Ana and Perez Velez for nominating me for this award, and especially for the Warao people that received me for more than 2 years to work with them. Thank you.
Congratulations to all of our award winners. I'd like to call Luchika Ditu up to the podium a moment to say just a couple of words about the World TB Day for 2015. I've seen those heels, Luchika. You don't have to run.
Actually, that's easy. So good evening, 30 seconds. World TB Day 2015 is coming. We will try together to continue to fight to find the missing 3 million TB cases. But after discussions with all of you, we realized that we should not fight just for the 3 million to be found and treated and put on treatment and cure, but we should fight for everyone that needs a treatment and a diagnosis to have access to it. So the 2015 World TB Day theme will feature treatment and care and diagnosis for everyone. And we will work with all of the organizations to make sure we go for the right slogan and the right message. Thank you.
Well, I don't really have another award to give, but Regida, you have to come over here just 1 second. I think everyone here knows Regida Bavaraju. She's been our program chair of the Scientific Coordinating Committee for the last 4 years, a daunting task in and of itself. And so we don't have an award, but we have, I think, the largest floral arrangement I've actually ever seen as a large thank you for all of your work for the last 4 years. Okay, we've neared the end of this opening ceremony. I just have a few details to just remind you about. Saturday is the General Assembly at 8 o'clock. Remember that this is the business meeting of the union, and that is also where the honorary memberships are awarded, the Union Medal, and the winners of the Christmas seals will be announced. Closing ceremony and the reception will be on Saturday at 16:15 to 18:30 in room 112. In 2015, the Union, Africa, the Asia Pacific, Middle East, and North American regions will all hold their conferences. We also wanted to remind you of the upcoming World Conference on Tobacco and Health in Abu Dhabi. And of course, go ahead and put your calendars for December 2nd for the 46th World Conference in Cape Town, South Africa. So let me be the first to welcome you to the welcome reception. It's going to be in the banquet hall in level 2. Enjoy the conference, build a community. Thank you.